So we see a lot of patients who are checking their blood sugars, and there's always a question as to when to start insulin and when to go up on insulin. So checking blood sugars, our goal for fasting blood sugars is 70 to 90. And ideally, our 1 hour postprandial blood sugar is less than 130, but we will accept 140 in our population. And if you're used to checking 2 hour postprandial, then the number should be less than 120. There's evidence that checking 1 hour postprandials are better than 2 hour postprandials. And I personally feel it is easier for patients to remember when to check a 1 hour instead of a 2 hour, because you're back busy in your day or back busy in your evening helping with homework and that type of stuff. So we adjust insulin when 25% of the values are abnormal. And in general, we do not make more than a 10% adjustment in insulin at any one time. We'll make 10% and then bring them back the following week, or call them in the middle of the week to go up if we need to go up more. We really try to keep the fasting blood sugars within the normal range, and we'll accept more of the postprandial values. You know, if it's random and it's related to food, we often counsel them very carefully about their food intake, and then may go up on their insulin the next time if they cannot adjust their diet. So it's important to understand the Samogi effect when you're checking blood sugars, and this is primarily due to a low insulin between 3 and 4 a.m. in the morning, and then because it went low, then it goes back high, and you get high blood sugars in the morning. This is particularly important on type 1 diabetics. I do not adjust a type 1 diabetic insulin to cover fasting blood sugars until I check a 3 a.m. value, and I check more than 1, 2 or 3 at a time. Because if it's due to undetected hypoglycemia, then you're just going to make your morning blood sugars worse, and you're going to put them at a higher risk for being in a coma. This is not common in a type 2 diabetic, and it's not common in a GDM, but I still get them to check a random 3 a.m. blood sugar to make sure it's not going really low, and I usually tell them less than 50. Fasting blood sugars, you often have to sit down and talk with the patient. Sometimes people, believe it or not, get up in the middle of the night and snack, you know, at 1, 2, 3 in the morning, or they'll get up and drink a glass of juice or something, and that is what causes their morning time blood sugars to be elevated. Now, we generally use NPH and either Humalog or Novolog. And one of the first things I talk to a patient about, if they're not snacking in the middle of the night, is when do they have dinner and when do they go to bed? if somebody eats at 5:30, 6 o'clock, and they're taking their MPH and Humalog, then what you might want to do is let them take Humalog with their meal, and then if they go to bed anywhere from 10 to 11, allow them to take their Humalog at before bedtime. The reason this is the case is because Humalog usually peaks around 6 to 8 hours and it's gone by 12 hours. And so if they're taking their MPH at 6 in the morning, then at 2 and 3 is when it's peaking, and then it's gone if they don't get out of bed until 7 o'clock in the morning. So the blood sugars, when you're looking at how the insulin you're taking is affecting the blood sugars, you have to remember several things. At breakfast time, your immediate acting insulin, your Novolog or Humalog, affects your postprandial value. At lunchtime, your immediate acting insulin or your MPH actually affects your postprandial lunch value. And then dinner time, it's your immediate acting insulin that actually affects your postprandial, and it's your MPH at night that reduces your fasting blood sugar. So when you're changing insulins, for example, if I go up on somebody's morning MPH, then I do not go up on their immediate acting insulin at lunchtime. Insulin sensitivity is only good for your type 1 diabetics, and it's either 1,800 divided by the total amount of immediate acting insulin, or 1,500 divided by the total amount of short-acting insulin. So type 1s can be much more sensitive to insulin. Sometimes you find it is 1 unit for 30 units of blood sugar or 1 unit per 40 units of blood sugar. They are just much more sensitive to insulin, and you have to be more careful with them than you do type 2s. In general, 1 unit of insulin in a type 2 lowers the blood sugar by 20 units or less, okay? But if they're very resistant, greater than 100 units total a day, I calculate that as 1 unit for every 10 units that I want to lower their blood sugar. So if I have a type 2 that's on 120 units of insulin and her breakfast is coming in high, again, I talk with her about the carbohydrates she's eating. And the second thing I do is if she's coming in at 250 and I really want her at 90, then that's 160. I increase her short acting by 16 units. I might go to 14 units if it's somebody who's really nervous about, if they're really nervous about low blood sugars. Again, we talk about increasing protein, we talk about decreasing carbs, and we talk about weight gain, because weight gain significantly changes the amount of insulin that patients need, and we talk with them about decreasing their calories and potentially exercising. Now, I don't know if we have a slide on this or not, But when patients come in and they say, I have a low blood sugar, we talk with them about correcting it with protein, a combination of proteins and carbohydrates. If they just drink juice or hard candy, then it's going to send them high faster, but they're going to crash on the other side quickly. So we talk with them about combining carbohydrates like a piece of toast with peanut butter on it, so that we have a combination of carbohydrates and proteins. And that's it.
Thank you so much. And this is just a brief sharing of the other telementoring programs in our state thus far. We have Project Echo Opioid Use Disorders. We have this Pregnancy Wellness, and then there is also a Southeast Viral Hepatitis Interactive Case Conference, which is a telementoring program as well. And if you're interested in any of those, you can contact me.
The only other thing I want to add is we often get type 2s. Should we leave them on their medicine, or should we start them on insulin at the beginning of pregnancy? And the main thing is, if you got a type 2 that's on more than 2 or more agents, you probably should start them on insulin from the very beginning, because the insulin resistance increases so much during pregnancy that it's highly unlikely that they will actually get through pregnancy without insulin. By putting a patient on insulin, we get better control than we do by trying to adjust their medications when they become out of control. The other time that I recommend a type 2 being started on insulin from the beginning is if they're only on one medication, and the one medication is usually metformin, and they have an abnormal hemoglobin A1C. The only way that we're going to get them in really good control is actually by starting insulin. And occasionally we do have patients that refuse to be put on insulin, and I don't advocate this, but I feel like it's more important to it's more important for us to control their blood sugar and try to work with the patient than it is just outright saying, well, we're not going to deal with you if you're not going to take insulin. And we will put patients on 2 oral medications as a very, very, very last resort. Other issue, a lot of patients come to you on 70-30 insulin, and we convert patients from 70-30 to NPH and Humalog or Novolog. And the reason we do that is it helps prevent hypoglycemia. The final issue I will say is, if you have a patient who is paying out of pocket and their finances, they have some financial toxicity, meaning that they're having issues paying their hospital bills and their bills for their medications and stuff, I personally had rather them use their insulin instead of not being able to afford their insulin. And so regular insulin is much cheaper, and NPH is much cheaper than NPH and Humalog or Novolog. Humalog and Novolog usually run between $120 to $150 a month, whereas NPH and regular, you can get by with that for $20 to $40 a month. And so I just keep that in mind if you have patients who have no insurance or are underinsured.
Thank you, Dr. Johnson.